Grandrounds series. I'm Dr. Mike Davis, and it's my pleasure to introduce Dr. Lambiase. He's the professor and the chairman of the Department of Medicine, a senior member of the academic GI practice here at Erlanger Health System. He is a graduate of the University of Miami School of Medicine and did his residency training in Pittsburgh Presbyterian Hospital for internal medicine and fellowship at the University of Florida College of Medicine in Gainesville. He's here to talk to us about an important and timely topic, especially at this point of the academic year: acute upper GI bleeding, what to do and when. There are the ABCs of acute intervention in the emergency department, including airway, breathing, and circulation. Those are the fundamentals. The C is not necessarily called GI. So give us just a minute, and Dr. Lambiase.
Thanks, Mike, and thanks to Team C for braving death and coming here and the coronavirus, and thank you very much. And it's now no longer my smallest audience ever, so that was good. So yeah, I'm going to speak today about acute GI bleeding, and really what I'm going to talk about is how to manage it. It's sort of early in the academic year. There's some new data. A lot of this is going to be old hat, especially for any gastroenterologists who may be listening. I'm actually not going to talk about any technical widgets and wangers and stuff that stop the bleeding, but just basically how to assess a patient, what to do, and that sort of thing. And there's some new data that just came out about timing of endoscopy that I think we'll talk about. So we're going to talk a little bit about, variceal and non-variceal upper GI bleeding. We're going to try and talk a little bit about how to tell the two apart without an endoscopy. We're going to talk about resuscitation, risk assessment, and pre-endoscopy management. We're going to talk about the role of endoscopy and the timing of endoscopy, and we're going to talk about post-endoscopy management for upper GI bleed. So just to make sure we all know what we're talking about, upper GI bleed is bleeding basically that arises from the upper GI tract, which is the esophagus, the stomach, and the first part of the duodenum. Usually mid-intestinal bleeding, or some authors will actually call it lower GI bleeding, will be from the distal duodenum, really the ligament of Treitz, in the jejunum, and then lower GI bleed is colon and rectum. Or lower GI bleed is from the ligament of Treitz, depending on which author you read. I think this mid-intestinal bleed is now that we have some new tools where we can look there, I think this is the way that we're stratifying things now. But if you read older literature, the lower GI bleed was anything from the ligament of Treitz which include most of the small intestine and the colon. So just sort of to sort out what we're talking about, because this is one of the hardest things for a gastroenterologist when they interface with our colleagues either in primary care specialties or emergency medicine, is just trying to get on the same vernacular. So I wanted to kind of get a hold of the thing. So there's guaiac-positive stool, right? So guaiac-positive stool is occult blood in the stool. Does not provide any localizing information and does not tell us anything about what's going on with the patient. So it just means that there's some blood in the stool. And so that you don't know whether that's a torrential upper GI bleed or whether or not it's a slow bleed. Usually in GI, when we talk about guaiac-positive stool, we're talking about a slow bleed. I will tell you, let me give you a couple of pointers. The first one is, if somebody's been admitted to the hospital, is on 4 pressors, and is septic, it would be a case report if they did not have guaiac-positive stool, right? So everybody has heme-positive stool. If you take a couple of aspirin, you will have a heme-positive stool. Right? So telling me their stool was heme-positive, usually the consult we get is their hemoglobin dropped, and they were admitted, their hemoglobin was 12, now 9 days in the ICU later, their hemoglobin is 9, and they're heme-positive. Well, that doesn't tell, and then I'll ask, are they bleeding? And then I'll get a repeat, they're heme-positive. Well, that doesn't tell me anything, to be honest with you. So that's an important, I think, point. The other thing is all emesis is heme-positive. Right? So don't gastrocult the emesis, right? Doesn't matter, right? What we're going to tell is by how it looks, right? Melena is dark, tarry, foul-smelling stool, right? Usually suggestive of an upper GI bleed, although a right colonic bleed can occur with this, right? And it's melanic stool, not melanotic, it's melanic. Melana, I think, is from the Greek word meaning black, right? Melanin. And hematochezia is bright red blood per rectum, right? Bright red blood, dark red, maroon. And remember, that can also be an upper GI bleed, too, if the patient is usually unstable. You can have an upper, so that doesn't tell you anything. So 68-year-old guy presented with large amount of bloody vomit, describes bleeding as large volume, also has very dark maroon-colored stools, has occurred 4 times, the vomits 4 times over the last 3 hours. He felt lightheaded and nearly passed out about trying to get up and go to the bathroom. He denies abdominal pain, nausea, vomiting, or retching. He has no history of heartburn, dysphagia, or weight loss. No history of diabetes, diarrhea, constipation, or hard stools. Never had a GI bleed, but he does goody powders for headaches. And screening colonoscopy 10 years ago, no polyps, and had diverticular disease. So this is actually fairly common, right? Painless upper GI bleed is fairly common in older people who take non-steroidals. And thank God for goody powders. They sent both my kids to college. So what's the differential diagnosis in this? Upper GI bleed. What do you think? Well, ulcer would be at the top of my list. I guess esophagitis. There's nothing that you talk about varices. Everybody worries about varices, but unless there's a history of liver disease or stigmata of liver disease, I don't usually worry about it. And what we really need to know is think about that and then also determine how sick is this patient. So obviously there's a clue in the history about how sick he is. He's had red stool and an upper GI bleed, so that makes you think things are fairly brisk, right? Because most people, when they have an upper GI bleed and it's more indolent, the stool has time to turn black. The other thing is he has orthostatic dizziness, which makes you worried. So right off from the history, you tend to be more worried, right? And so, the most common causes of upper GI bleed are peptic ulcer and varices in people with liver disease. We do see other things. This lesion, Mallory-Weiss tear, usually you can get that's a tear at the gastroesophageal junction where you can have from retching. Usually you can get a history that will tell you that they retched a couple times and then they had red emesis. Erosive esophagitis is something that we see a fair bit. Usually there's a history of prolonged nausea. A lot of our gastroparesis patients will have nausea, vomiting, sort of prolonged. You get a history of like prolonged gastric stasis, and then they threw up blood. Usually it's not a torrential amount of blood, and when we scope them, we see esophagitis, not uncommon. Vascular ectasias, you can see, I'm not going to talk about it. Neoplasms usually don't bleed briskly, but occasionally they do when they erode into something bad. And then a Dillefoy lesion is a vessel that's eroded through into the GI tract without an associated ulcer. They're supposed to be rare, but we had a 1-year period here in Erlanger about 4 years ago where we saw 1 or 2 a month. So for some reason we had a rash of Dillefoys. And then these other things are actually very rare. It kind of sucks if you miss them. Aortoenteric fistula, because they don't stop on their own. And hemobilia and hemosuccus pancreaticus are basically bleeding into the biliary tree or into the pancreatic duct, usually associated with chronic pancreatitis. So with we talked about the history a little bit. Obviously it's nice to know if they're had radiation exposure, if they've had valvular disease, if they have any other things, signs and symptoms of liver disease. And then also on physical exam, you want to make sure you know the vital signs, the orthostatics, whether or not they have abdominal tenderness. And then this is actually pretty important, because this helps, especially if you're going to call me and I'm not in the hospital. This is actually really important, is getting an objective description of the stool, whether there's blood, also knowing if there's a mass. And when you're assessing an upper GI bleed, like this guy, you don't need to guaiac his stool, right? You just don't need to, I don't need to know whether it's guaiac positive, right? You told me he threw up blood, he's got red stool, right? The guaiac test adds nothing, right? So you don't have to do it. There's a slide later that says you don't need a card to tell me that it's an upper GI bleed. You don't, okay? So, but this is important, stigmata of liver disease. Obviously, oral examination for the one patient in your career that's going to have Putz-Jaegers or something like that, you know, where they have the Teller, Osler, Weber, Rondeau or something like that. I had a interesting, there is a patient who's been around who has hereditary telangiectasia, and he's funny because he's got the sense of humor. He said his best moment in coming into multiple admissions he's come in with upper GI bleed is when a medical student asked him how long he's had hereditary telangiectasia. All right, so always get an objective description of the stool. You know, so that is important to me. Like, is it red? Is it black? Is it brown? Because to be honest with you, if you have a brown stool and the guy's thrown up and he's otherwise stable, guess what happens? I roll over and go back to sleep, which for you may not be as important, but for me, look at me, I need my beauty sleep. And also, please avoid grossly non-informative terms such as grossly guaiac positive. You know, I don't know what that means. So what did you see? Is it black? Is it red? Is it melena? You know, is it not grossly heme positive? That means nothing to me. So that just as an aside. And every patient should have a rectal exam and a description of the stool, especially before GI is consulted. And then if you need a card to tell you whether there's blood in the stool, it's not an acute GI bleed, right? So the little old lady who comes in with a hemoglobin of 2 because she feels weak and dizzy and has brown stool, it's not an acute GI bleed, right? It's not an acute upper GI bleed. You know, it's useful to know if she's got blood in her stool because it's useful to, so that's a time where it's useful to know it, but it's not an acute GI bleed. It's not an emergency. It's not something that, it's not what we're talking about today. What we're talking about is an acute GI bleed, right? So, in other words, somebody comes in and they're weak and dizzy, and their hemoglobin is 5, and their MCV is 40, and they've got no melena, and they've got, you know, heme-positive stool. You don't need to call GI at night, bottom line, okay? You can call them the next day. They'll need a workup. They need an evaluation, but they just don't need it at night. It's not an emergency. Okay, so how do you know if something's an upper GI source? Well, age less than 50 would be an upper GI source. Melena would be it. And also the BUN to creatinine ratio can be very helpful too, right? If the ratio is greater than 30, think upper GI bleed. So if somebody's BUN is high, that can be sort of a sneaky tip-off that it's an upper GI bleed. It's actually interesting. There's a debate about whether it's the blood that causes the high BUN. There was a horrible pre-IRB study where sometimes slipping an NG tube down can help, right? If you have you can still have a negative upper GI aspirate in an upper GI bleed if it's post-pyloric. But if somebody has red blood per NG tube, it's actually a very good indicator that there's a high risk lesion. So this is this is one of the things that's changed dramatically since I got involved in medicine when Earth's crust was cooling. You had, one time we would actually lavage and we would use ice water and stuff to try and stop bleeding. That has no effect on it. But I think if you have somebody and you're not sure it's an upper or lower GI bleed, snaking an NG tube down can sometimes tell the difference and will help us decide which way to go. And that would be and also coffee grounds. If you have coffee grounds that clear, it's usually a lower risk lesion. So that can be helpful on certain selected occasions. You know, I think we're losing the skill of using NG tubes, and so they can certainly be helpful. Certainly, I can't tell you how many small bowel obstructions I've been consulted on where people didn't put an NG tube down or the nurses didn't know how to use them. So I think they can still be useful on occasion. They're not, but this last thing is what everybody hangs their hat on is that a negative aspirate still has a 15 to 20% chance of upper GI bleed. So, but a positive aspirate, it's pretty hard to fake. So I think it can be helpful. The other thing is sometimes irrigating will clear blood out of the way. One of the problems we have is when somebody's bleeding briskly is we can't see. Usually there's a pile of blood in the fundus, and we can't get good visualization. And so sometimes this can help. Very often it doesn't, to be honest with you. So upper GI bleed must still be considered in patients with severe hematochezia. So somebody comes in and they're bleeding like thunder out of their rear end, and but they're orthostatic and they're shocky. You still have to think about an upper GI bleed no matter what. So what's the initial assessment? It's just like Dr. Davis said, ABCs, right? And this is a way to look at hypovolemic shock. So the thing that we get all the time is we get I don't think anybody gets confused around here about when people are really in hypovolemic shock. They kind of can tell, but a GI bleed that causes hypovolemic shock usually produces blood that you can see, right? So there's blood on the bed, there's blood on the sheets, there's blood on the walls. There's not. So that what we get the consult that we get where people get there is. I mean, it's like a slaughterhouse, right? It's like somebody did a chainsaw thing. I mean, there's blood everywhere. Usually a real, honest to God, upper GI bleed is not subtle. It's the people melena, they're pooping blood out their bottom. It's not subtle, right? Where we get a consult is we get somebody comes in, they've got septic shock from a UTI, a pneumonia, osteomyelitis, pick something, and when they intubate them, there's a lot of coffee grounds that come up, right? So remember what I told you about? It's a case report if you're septic and you don't have a heme positive. So these people all have gastritis, right? They all have stress gastritis. It's not a fixable lesion. It's not a big part of their thing, of their presentation. And then they're on 3 pressures, and then you go to the chart, and their hemoglobin's 11. Right? And you go to the chart, and people are writing hypovolemic shock. It's not hypovolemic shock. It's septic shock. Small thing, so endoscopy really doesn't help with septic shock. And some of the medicines that we use may actually vasodilate and may make things worse. So to sedate. So really, it's important to separate that out, right? But septic, severe hypovolemic shock is usually greater than 2 liters of blood loss or 40% of the volume. Heart rate's usually high. Blood pressure is low. Urine output's low, and they can be confused. It's sort of like sepsis. To me, the big difference is, and Mike, you can probably back me up on this, is if I grab their feet and they're cold and they're not on pressors and their blood pressure's low, to me that's more hypovolemic, and they're obviously all things being equal, and if their feet are warm, it's usually a sign they're vasodilated and it's more sepsis. I mean, it's a very gross way of looking at it, but I'm a simple man, but I think that's the way you can tell. So what do you need to do? Give them some fluid would be good. Use crystalloids first. I think there's some benefit probably to lactated ringers as a resuscitation outside of liver disease, because people worry about too much saline and the chloride and that sort of thing. But anything is better than nothing. And then anticipate the need for blood transfusion, right? So if I slit your carotid right now, your hemoglobin on the last drop of blood would be normal as you bled to death in front of us in a big pool of mess. So you can't, if somebody's bleeding like you read about, like we're talking about, serious GI bleed, and their hemoglobin is 8 and their blood pressure is 70, they need a transfusion, right? The guidelines are important for chronic bleeding and that sort of thing, but you wouldn't hold a transfusion for somebody who was shot in the aorta until their blood count got to 7, right? Because you might miss the, think about, it's August, so we now know that we don't immediately get every lab back and that sort of thing. So just we have to anticipate it. And that being said, you don't want to over-transfuse people, and you don't want to overdo it. So somebody's stable, there's no need to transfuse them. But if they're shocky, err on the side of transfusing them, especially if they're anticoagulated or something like that. 1 unit of PRBC raises the hemoglobin by 1, and that the initial hematocrit can be misleading. It can be overstated. I mean, we see this all the time, right? Somebody's hemoglobin 6, they get a unit of blood, the next one's 8, and then we get called in a panic because it dropped to 7, because we see this all the time. The other thing that nurses tend to like to do, just as an aside, is draw hematocrits above lines. And so if you get somebody's trotting along at 9, and then all of a sudden it's 6, and the patient's not bleeding, right? Because 9 to 6 should be 3 units. If you look and there's no blood on your shoes, right? There's no blood around. There's no bruise. There's no reason for them to bleed. You have time to repeat the hemoglobin, just as an aside to see, because we've seen that the other day. We saw that just the other day. So, right, this is just, it takes, that if you bleed, and then the other thing that happens is that when you give IV fluids, right, and you expand the blood volume, remember, the hemoglobin and hematocrit are basically expressed as a proportion of the blood volume. So if you expand the blood volume with crystalloid or colloid, you'll expect the hemoglobin to go down, but it's the same amount of blood. Just an aside. This was an interesting study from the New England Journal in 2013, where they looked at transfusion therapy and where they in upper GI bleed, 921 people with a severe acute upper GI bleed, and they transfused when the hemoglobin was 7 with a target of 7 and 9, or this must be the bad old days when the hemoglobin was, they transfused hemoglobin of less than 9, and they looked at all-cause mortality within 45 days. And guess what? If you had the restrictive strategy was superior, right? All mortality was less, a rate of further bleeding was less, and the complication rate was less with restrictive bleeding. But what was interesting is if you tease it out, it was mainly with cirrhotics, right? The benefit was mainly with cirrhotics and not with ulcer bleeding. And so there's a thought that maybe if you transfuse too much, you increase portal pressures and you increase bleeding. So it's not clear whether this is really an ulcer bleeding. I would say that you have to, I think what we're taught about transfusion is right. I just worry that sometimes when people are jumping up and down, it's sort of incongruous. I'll get a call that I'm worried, you need to come in, you've got to do something, you've got to do something right away. Did you transfuse the patient? No, their hemoglobin's 7.2, right? It's like, well, yeah, but they're bleeding to death. So I think you have to be careful about over-transfusing, but I think that because the outcome is better if you don't, but on the other hand, you don't want somebody to bleed to death on your watch. And then anticoagulation, right? So what do you do for anticoagulation? I think that, if you have to weigh the risks and benefits. If somebody has a large clot sitting somewhere that's poised to infarct their brain, you may not want to stop the anticoagulation. You may just try and ride out the bleed if the bleeding's not too bad. But most of the time we'll try and correct it either with FFP or a lot of times now, because everybody's on a DOAC, is we'll just wait. We only use the reversal agents if the people are shocky, because those are I think it costs like about $10,000 to use Praxibine or the other medicine whose name escapes me that reverses Xarelto and Eliquis. But so we usually don't reverse them unless the patients are shocky, and so we'll wait a day or two before we scope the patients, and usually we'll give FFP. And then remember, when you're transfusing somebody massively, you give 1 unit of FFP for every 4 of packed red cells as well. So, well, what is the most important thing for upper GI bleed? Well, it's actually gresuscitation. Early intensive resuscitation reduces mortality. So in the American Journal of Gastroenterology, a long time ago, they looked at 2 groups, 36 subjects in each, where they had intensive resuscitation. And guess what? They said most the groups were the same, and the time to endoscopy was similar, but one group had a faster correction of hemodynamics, hematocrit, and coags. And guess what? The mortality was much better in the people who were resuscitated. So it's not hard to believe. It's kind of interesting that 80% of the deaths that are related to upper GI bleeds are not bleeding deaths. Most people do not bleed to death with upper GI bleeds. Most of them, they're cardiovascular and other mortality, obviously. And so this was a study, this is from 2010 American Journal of Gastroenterology. They looked at about 10,000 cases of upper GI bleed. The mortality was significant, 6.2%, but it was interesting to me, 80% of people rarely bleed to death. And usually, a lot of times it's malignancy. It's almost hard to count them because they're bleeding from their malignancy or multi-organ failure, pulmonary disease, cardiac disease. We just had a guy who had a variceal hemorrhage that we stopped the bleed. He did fine, but then he got progressive. His liver disease got progressively worse, CRRT, and then died. So he died of multi-organ failure. So I think that's interesting. And I think that if you resuscitate the patients, you're less likely to have mortality from upper GI bleeding. And so early resuscitation is the key, right? So early resuscitation means giving blood and crystalloid and making sure that and restoring hemodynamics. There's nothing in here right now about endoscopy, right? It's early resuscitation is more important than early endoscopy. So how do you tell who's sick and who's not? Because sometimes that can be tricky, and you can identify people who are at high-risk outcomes. You can also, there's some people with an upper GI bleed who can be sent home, and then they can also be, you also can help you determine endoscopy. So there are 3 scoring systems, and you can pick the one that you like. There's this Rockall, and you can, MD Calc has them all. So you can look, there's this Rockall scoring system, which basically looks at age, shock, and comorbidity. The more comorbidities you have, the sicker the patient is, the more likely they are to be sick, and the older you are. I think this is this Rockall goes under the heading of why didn't I think of this, right? The older you are, the lower your blood pressure, and the sicker you are, the worse you do. Like, yeah, that's earth-shaking stuff. But the more crap you've got on a Rockall score, the worse you do. But the thing is if you have 0, you have a very low mortality. So that's really the take-home message here. There's this AIM-65, albumin, INR, mental status, systolic blood pressure, and age. That also works pretty good. And then the one that we use a lot is this Blatchford Score. And, MD Calc has it in milligrams per DL. So this is the European version of it because this is from the Lancet. But you can do scoring. But the sort of the take home is that's much cheaper. The take home is that people with a Blatchford score of 0 can be sent home, right, with close GI follow-up. That's sort of the take home. They're low risk, right? The likelihood is that therapeutic endoscopy is not required. If you don't, there's an old data from the early 90s where if you scope patients and you don't do anything therapeutically, you don't change outcome. And all of those patients would have 0 Blatchford score. So Blatchford score 0 can go home. And so what's the new thing on this? Well, the new thing is, this is hot off the presses from January of gastroenterology, is of course machine learning, right? AI, looking at all the clinical variables. And I think I can see a time when this gets baked into Epic. And so it'll be another thing that pops up in Epic, which I personally love it when stuff pops up in Epic. Warning: this patient is allergic to pumpkin seeds, so therefore you shouldn't prescribe the toenail medicine that you prescribed. I love that. But anyway, I think that one of the things that these fellas did is they've been working for years now on this AI algorithm to look at how they predict upper GI bleed. And one of the things that the interest is in, the specificity is pretty crappy. So in other words, if you to look at, if they have any score, any prediction of anything, you have to be careful and admit them and do it. But the really low-risk patients, they're able to tease out. And so using this cutoff, out of 800 patients, they could have sent home twice as many as using the Blatchford score safely, and they validated this. I won't go through the whole paper because we don't have time, but they validated this and all of that. So I think that this is coming, and this is basically just looking at more variables than we can put in, and it performs a little bit better. Although the Blatchford score actually does fairly well, right? To be honest with you, the Rockall score not so much, but I think that's interesting. So low-risk patients can be discharged from the GI follow-up. So what do? You give them. We put everybody with a non-variceal upper GI bleed on some PPI. This is an old slide that I stole off the internet, but drip is not done very much anymore because intermittent dosing is non-inferior and it's cheaper. I will say that the study may not have been powered enough to detect some people who do better with the drip. You know, in other words, I suppose somebody's really wailing and they've got a very big vessel. There might be some of those patients who do well, but for the most part, you give BID dosing, and you do it until we do the EGD, and then you can, based on the findings. If you do, it tends to down scale. So what we find in the endoscopy, you know, if you have a high risk stigmata, so you either have a pumping vessel, a visible vessel, or bland ulcer. Usually, there's some intermediate steps, and that's high, medium, and low risk. And pre-endoscopy PPI decreases usually down stages, but has not been shown to reduce rebleeding or mortality rates. So if you don't do endoscopy and you have a high risk lesion, the chances are that you'll have continued bleeding. So the two are this active bleeding or a vessel that's pumping blood. Their rebleeding rate can sometimes be as high as 90%. Or you have this pigmented protuberance or non-bleeding visible vessel. I'll show you a picture in a minute. And that's about 50%. And then these are much lower, flat pigmented spot, clean-based ulcer, less than 5%. And an adherent clot, you have to figure out. So we actually take the clots off. So if we see an ulcer with a clot, we'll try very hard to remove it so we can see what's underneath. It's counterintuitive and gives me diarrhea, but that's what we do because it's the best thing. So this is the New England Journal of Medicine paper, came out in April. And this slide didn't project very well, but basically what they did is they looked at all-cause upper GI bleed, and they said if patients were able to get their vital signs back, resuscitated, so they're resuscitated and stable patients, not unstable, so their vital signs they're not shocky, they don't have persistent shock. So they may come in, their blood pressure may be a little low, but with initial resuscitation, their vital signs become stable. There was no difference in outcome whether you scope them between 0 to 6 hours from presentation or 24 hours from the GI consultation. So in stable upper GI bleed patients, there's no difference in outcome scoping them up to 24 hours after the GI consultation, right? So somebody comes in at 4 in the morning, pukes up some blood, has melena, but their blood pressure is 110/70 and their pulse is 90, and they're otherwise stable. We don't need to call GI until the morning. You don't need to call GI until the morning, right? You trend their stuff. You know what to do. You don't need a gastroenterologist. You just need a doctor. So unstable patients obviously require urgent endoscopy, and stable patients can wait. But unstable patients require urgent endoscopy. So you can't get their blood pressure to. So unstable doesn't mean that they're throwing up blood, right? It's that their vital signs become unstable. It's really scary when somebody fills a toilet bowl with blood, but the real question is are their vital signs stable? What are they doing? What's their hemoglobin doing? That sort of thing. So scoping is not magic and is often the less important part of the management of upper GI bleeding. So these are just some of the things that we see. These are actually gastric varices. This is a scope. These are esophageal varices. This is very common what we see, right? So we'll see there's a big old clot sitting. This is looking down in the duodenum probably, and there's a big old clot. You can see the cratered ulcer. You can see the cratered ulcer here, and I can't tell what's going on here. This is actually what a spurting blood vessel looks like. You can see the ulcer here in the stomach, and I guess the poor guy went to surgery, and that's what they're showing you here. But this is what it looks like. This is actually very easy to treat. To be honest with you, it's exciting but very easy to treat. And then this is a non-bleeding visible vessel, right? So you've got this is duodenum. Right? You can tell it's duodenum because it's villous looking. There's this ulcer base, which is with the fibrin and everything, and then you've got this pigmented protuberance. So this is so this has about a 50%, 50-50 whether this bad boy would rebleed This bad boy's got about a 90% chance of persistent bleeding unless we fix it, right? And this one we don't know until we suck the clot out of there. So, so here's another adherent clot. We see this all the time. So there's an ulcer under here. You can just get see that white rim. There's an ulcer under here. This is again probably duodenum, and then there's this adherent clot. So we remove it. The way we do it is we actually will. I personally will inject under here with epinephrine to try and get at whatever's under there to sort of constrict, and then I'll take a snare and slice through it and pull it off, and then take a big deep breath and see what's under there. So these are the low-risk lesions. This patient, this is a clean base duodenal ulcer, right? This person can go home, right? Less than 5% chance of rebleeding. This patient can go home. Right? This patient can probably go home too. This is a 10% chance of rebleeding. So these two people, if you have a patient that you've sent and we've scoped them for some reason, and then they've got clean-based ulcer, and they've got reasonable follow-up and no other reason to keep them in the hospital, kick them out. Right. And then so there are all kinds of tricks we can do. We can do epinephrine injection. We can put clips, we can burn things. There's actually now a hemostatic spray that we can use, and it's beyond the scope of what I want to talk about here. It's more of there's also these big over-the-scope clips now that we can either stop bleeding or cause a real big complication by using. And so there are all of these things. That's more for the GI folks that we're going to talk about. And then sometimes we can't stop the bleeding. For whatever reason, you can't see it. It's in a technically difficult place. Sometimes endoscopic therapy works better when you're on FOS or when you can see things, but when you're tucked around a corner, sometimes it's hard to see. Some of the ulcers are very indurated, and so you can't get clips and stuff on them, or the vessel will actually be below this fibrous tissue, and so burning into it, you worry about causing perforation. And so in those cases, interventional radiology is really our go-to, and they'll do an embolization, and our guys are very, very good at it here. And they say nationally now, only about 10% of acute upper GI bleeds get surgery. I actually can't remember the last time that somebody went to surgery for an upper GI bleed in our institution. Usually either a GI or endoscopy can do it. Maybe for recurrent bleeding, maybe for recurrent ulcers, but acutely, I can't remember the last time somebody went. Certainly for ulcer bleeding, I'm trying to think. Maybe probably once in 10 years, but I can't remember it right this second. So post-endoscopy, low-risk ulcers can be fed promptly and probably sent home and put on an oral PPI therapy. Patients with high-risk ulcers should receive a proton pump inhibitor IV for 72 hours because it reduces the 30-day, I should have fixed that, 30-day, it's not a drip, but IV, reduces the 30-day rebleeding rate versus placebo. That's the same slide. And then all patients with ulcers need H. pylori status determined, right? All patients with ulcers, because the rebleeding rate is very, very high if you don't eradicate H. pylori. And so if the patients are H. pylori positive, you need to put them on therapy to eradicate it, and you need to make sure that the H. pylori is eradicated. So they need post-therapy testing, usually stool antigen or breath test, to do. So people with duodenal ulcer don't need to be rescoped. So you don't have to rescope them to determine it, but you really need to make sure that H. pylori is eradicated. I would say it's probably malpractice to not do that. And discharge patients on a PPI, and then also look at NSAIDs and aspirin. And then we'll focus on this a little bit, but you have to restart the anticoagulation as soon as possible, right? And you need to. There is rebleeding, and rebleeding's a problem. But patients have a much lower mortality if you restart their anticoagulation. If they have cardiovascular disease, you need to restart their anticoagulation, and because not dying is more important than not bleeding. I also say you can give blood, but you can't give brain. So, so this is just an interesting. This was the dreaded Danish cohort study from British Medical Journal. They looked at 4,000 patients with AFib and GI bleed. I think this blew me away. Don't have AFib and GI bleeding in Denmark, because if you do, you have a 40% 2-year mortality, just horrific. But the hazard ratio for mortality, it was 0.39 if anticoagulation was restarted, so it's much lower. 0.76 if you antiplatelets, and 0.41 for combined antiplatelet and anticoagulation. So much lower risk of dying if you restart their blood thinners, right? So this, to me, for me this has changed a lot of things. You know, nobody's blood clots anymore, just like nobody makes stomach acid. But I used to be very reticent, but I think this data, to me, is compelling. And there is a higher risk, obviously, of GI bleed when you restart it, but it's worth it. This was a study from American Journal of Cardiology looking at warfarin patients, and the mortality was lower and without higher GI bleeding, and those were starting 7 to 30 days. Most people will now start the anticoagulation in about 7 days after the bleed. Warfarin you could probably start in 4 because it takes a while for it to come back up. But most people need theirs. So restart the anticoagulation, right? We just had a patient come in who was at another outside hospital who had a GI bleed and went home without his anticoagulation, and on day 31 had a large MCA stroke. So when we came here, we put a PEG in him. You know, so these are important. This is an important, I think, important stuff. So just what I said, you can have a heparin bridge if you have a high-risk lesion. So somebody comes in and they've got some thrombotic, or they're had an acute, so you're really high risk for thromboembolic events after AFib ablation, for example. But if somebody comes in with an upper GI bleed, that's somebody you may actually want to bridge with heparin or Lovenox or something for a couple of days before you restart the thing. And then the other thing, this is mainly from my colleagues, aggressive hemostasis. So what that means is you use clips where you can, and stuff where you know that they may not rebleed. That's sort of there's no data on that, but I think it just makes sense to me. So restart the anticoagulation in 7 to 30 days. Variceal bleeding, about a third of the patients with cirrhosis, very, very high. 1/3 of the initial bleeding episodes in some studies are fatal. It's not really that high. I think our experience is about a 15 to 20% fatality rate. A lot of rebleeding, and only 1/3. It's a marker of death. So cirrhosis with variceal hemorrhage is worse prognosis than a lot of malignancies now. So it's a very serious thing. How do you tell? Well, if they have liver disease, that's a good tip-off, right? Not that they're a drinker, but they have liver disease. Usually their platelet counts are low. Really hard to have a variceal bleed and have a 280 platelet count, right? If you have a palpable spleen, not that anybody does physical exam, but if there's a big spleen on the CT scan that everybody gets in the ER, I guess I walked through the ER the other day. I got two CT scans on myself just walking through there. But if they have a big spleen, if they have stigmata of end-stage liver disease, that sort of thing, if they've been told that they have cirrhosis, that's how you can predict. I don't know anybody who does platelet count to spleen diameter, so I'm just, but that's one of those things that's out there. How do you treat them? It's sort of the same thing. There are a couple of different ones. There's vasoconstrictor therapy, and antibiotics are also involved in this. The big one that everybody uses now is octreotide. It's just a somatostatin analog. It decreases portal pressure. One of the problems with somatostatin is that there's no data that actually supports its use. I was part of the largest trial of lanreotide, which is another somatostatin analog that they were trying to get to market in variceal hemorrhage, and it was multiple thousands of patients, and we didn't meet primary endpoints, and so the drug went away. There's a lot of anecdotal data on it, and it's a matter of religion. I think I think as gastroenterologists, we support it so that we can, go back to bed, because it gives everybody something to do. But it's not. There is no proven randomized control trial that shows a benefit here. So, we keep it on for a couple of days, and we think it helps, But if you don't think that somebody has varices and you don't use it, it's not a crime, right? Because it's expensive. It's thousands of dollars. One of the interesting things is variceal bleeders and people who undergo variceal hemorrhage and banding need antibiotics, right? And why do they need antibiotics? It's 5 to 7 days of antibiotics, and they think that bacterial infection can happen in about 66% of patients with cirrhosis and variceal bleed. So portal hypertension, there's a whole bunch of negative things that happen in regard to gut bacteria. There's a lot of translocation of gut bacteria from the intestine into the portal circulation. The reticuloendothelial system is stunned. The portal hypertension causes translocation into the systemic circulation. There's, like I said, a lot of different things. There's a stimulation of these endogenous heparinoids. So actually, prophylactic antibiotics. This is a trick question, but what does prophylactic antibiotics improve? What endpoint do they improve in patients with variceal bleeding? And the answer is rebleeding. It's not necessarily infection. It's rebleeding. There's a lower rebleeding rate. This is from multiple studies. So 5 to 7 days of antibiotics. Doesn't all have to be inpatient, but that's the standard of care. And then resuscitation. These are the people that you really don't want to over-resuscitate, right? So these are the people that, remember that study that I showed earlier. These are the people that when you over-resuscitate, they do less well. And so you'll sometimes see a note saying don't over-resuscitate, don't transfuse hemoglobin greater than 9, be careful with the resuscitation. And the thought is you're increasing portal pressure and you're making things worse with bleeding. So in summary, resuscitation saves lives in upper GI bleed. Resuscitation saves lives in upper GI bleeding. Low-risk patients may be discharged, right? So Blatchford score of 0, magic machine learning, low-risk score, AIM-65, low-risk score, and low-risk stigmata on endoscopy may be discharged home. H. pylori should be checked on all patients with ulcers. Stable patients may have endoscopy within 24 hours without adverse outcomes and restart the anticoagulation within 7 days. So, and then these are the people whose slides I stole for the talk. So, with that, I'm done. I know that we've got Team C if you have any questions or if there's any issues. Dr. Davis.
So in septic shock resuscitation, protocol resuscitation really made a huge mortality benefit in the early 2000s when we started using Rivers algorithms for mean arterial pressure, and mixed oxygen saturation, and we set up a time frame for when to do it. So is there something like that in GI bleeding where this is when we check the lab, this is what we check, this is how we do the resuscitation?
So the question was whether or not, as in sepsis, does GI bleeding have the same thing as sepsis where there's a protocolized resuscitation with timing for labs and et cetera? And to my knowledge, there's not. That's gained wide acceptance. Although I think some of the same, I think it probably would work. It's probably a study waiting to happen, is my guess, because there are those studies about rigorous, so there are studies that showed they have rigorous resuscitation algorithms in them, but to my knowledge, they've not been, as codified as a GI bleeding. It hasn't been adopted the way sepsis has. Any other questions, problems, concerns? All right. Well, I appreciate everybody here. Rock on, dudes, and everybody in the airwaves, and I appreciate it. Thank you very much. All right. Well, thanks.